Hello, everybody. My name is Dr. Al Heuer. I'm a professor at the Rutgers School of Health Professions. I'm an adjunct faculty at the County College of Morris Respiratory Care Program in North Central New Jersey. I'm also the editor of 3 textbooks in respiratory care, including Egan's Fundamentals of Respiratory Care. However, I'm coming to you now in a different capacity as co-owner of A&T Lectures with Terry Shenfield. And for the next 50 minutes or so, I'll be presenting to you on a topic related to performing and interpreting ECGs, also known as EKGs. I want to thank you for joining us today, and I hope you learn a lot in this session. So before we actually focus on the substance of the presentation, let's take a look at the structure of it. In particular, the learning objectives. The first 2 learning objectives are foundational to understanding ECGs. They relate to gaining a better understanding of the basic anatomy of the heart and describing the cardiac conducting system. Because many times it's issues that occur with the anatomy of the heart and the conducting system that account for abnormal ECGs or EKGs. We'll also focus on the indications for ECGs or EKGs. We'll summarize the basics on how to analyze the ECG. We will review some common dysrhythmias or abnormal heart rhythms, as well as the causes and some of the basic treatment. Probably most importantly, however, I'll be furnishing you with additional resources should you want to actually drill down and learn more about this topic. Now let's take a look at the conducting pathway of the heart. So the heart beats because of the exchange of positive and negatively charged ions or electrolytes. It's known as the action potential. And likewise, there is an internal pacemaker in the heart. So the heart indeed receives signals from the central nervous system, but the heart also has an internal conducting pathway. And if you focus on this diagram for a moment, you'll see at the top, it's actually labeled the sinoatrial or SA node, number 1 there. It is the dominant pacemaker for the heart. It accounts for the average adult heart rate being between 60 and 100. Then if you move further down the conducting pathway, you'll see the atrioventricular node or the AV node. The AV node will actually beat for the heart, but it will beat at a lower rate of about 40 to 60. So it's certainly enough to maintain adequate blood and oxygen supply throughout the body in most circumstances. But it doesn't do so as well as if the SA node is the more dominant one. So some of the issues that can occur that account for abnormal heart rhythms have to do with an interruption between the conducting pathway of the SA and the AV node, where the AV node has to take over as the predominant pacemaker. And then if we move further beyond the AV node, and it really is towards what's called the apex, and we think of the apex sometimes as being the top. It's actually the point, so the point of the heart, if you will, if there's such a thing, it's a crude point. But the point of the heart is actually downward. So this conducting pathway moves further downward, and it basically moves from the AV to the bundle of His, to the left and right bundle branches, all the way down to the Purkinje network and the Purkinje fibers. And likewise, it is issues that can occur with this conducting pathway, such as if someone has a heart attack and they suffer tissue death in the heart, that can affect this conducting pathway and result in abnormal heart rhythms. This slide just actually complements the preceding one, and it gives you a better idea of when a pacemaker takes over, the dominant pacemaker being the SA. But when an escape pacemaker takes over, such as the AV at 40 to 60, or further down, the bundle branches at 30 to 40, and their Purkinje network also at 30 to 40. So again, when a escape pacemaker is forced to take over because of an issue, because of damage to the conducting pathway or damage to the actual node itself, then it can in and of itself account for bradycardia. An ECG or an EKG is simply the graphical depiction of that cardiac cycle, if you will, the conducting cycle. And we look at P waves, and P waves correspond with atrial depolarization. Then you will actually have a PR interval. And later in this presentation, I will describe a dysrhythmia that's simply a prolonged PR interval. It's actually first-degree heart block, but I don't want to steal too much thunder at this stage of the game. Again, later in this presentation, we'll talk more about it. The QRS complex corresponds with ventricular depolarization. That's where those ventricles squeeze. It accounts for the bulk of the blood ultimately, going out to the left atrium into the aorta to perfuse the body. Then we look at the ST segment, and particularly the T wave, which is the ventricular repolarization. And then the U waves, which are not always apparent, which again is this after potential that actually occurs here. And you'll see as we describe these abnormal dysrhythmias, if you will, a lot of them have to do with an abnormality in the shape. It could be in the interval as far as a prolonged interval. It could be where P waves sometimes are buried in QRS waves or just not visible at all. So now let's focus a little bit more on the rest of this presentation. Indications for EKGs or ECGs are as follows. If an individual presents with chest pain, and for example, the chest pain appears not to be of an orthopedic nature. So if the individual says, yes, it hurts when I press on my chest muscle, I fell I fell face forward on my chest, and it's starting to resemble something like a broken rib or a bruised intercostal muscle, or something along those lines. Then we would say it's probably not of cardiac origin. Okay, but chest pain that's not due to orthopedic issues, things along those lines, or a potential indication for an EKG. Dyspnea on exertion. Now, if you exert yourself enough, you're going to get dyspneic. But we're really talking about somebody who has had progressive dyspnea on exertion, so that now even their activities of daily living are becoming an issue. They probably should have an ECG. Orthopnea, which is the difficulty breathing in a lying down position. So you may have somebody who needs 3 pillows in order to sleep, or sleeps in a recliner. And they may have a cardiac history. It may be an indicator that they have or are developing congestive heart failure. Pedal edema is more associated with right heart failure because of the backup of the plumbing system. And I use the plumbing system, crudely. But basically, if the right ventricle is not functioning properly, the blood will back up into the right atrium and eventually into the mainly inferior vena cava, because it's gravity dependent, and you can develop pedal edema. Fainting spells that are not due to other indications, palpitations, some issues with past medical history, so a history of heart disease, history of cardiac surgery. It may even be a history of a family member, mother, father, having a heart attack, particularly at an earlier age, and you have the patient presenting at about that same age with similar symptoms. On physical exams, unexplained tachycardia at rest, hypotension, decreased capillary refill that's not explained by other reasons, abnormal heart sounds, murmurs, bruits, cool edematous cyanotic extremities, diaphoresis, And then the last one there is a positive jugular venous distension. So what you can also get with right heart failure is not just pedal edema, because of the backup, into the both inferior and superior vena cava. Individuals can get jugular venous distension because that vessel, the jugular vein or veins, are engorged because of the inefficient pumping of the downstream, if you will, pump or ventricle. Like all diagnostic procedures, ECGs or EKGs also have their limitations. They do not measure the pumping ability of the heart. In order to do that, you need other sorts of interventions, cardiac ultrasound being one of them. But there's also some of the newer technology we have. The flow track and the cheetahs have the ability to measure cardiac output with pretty close accuracy. You also have Swan-Ganz catheters that aren't commonly used, particularly outside of a cardiac care unit, but they can pretty accurately measure the pumping ability of the heart as well, certainly cardiac output. Likewise, ECGs do not show abnormalities of the cardiac structure. They don't have a predictive value in general. There's also artifact where you have a patient who's connected to an EKG and the leads have fallen off and it's showing some sort of something maybe that looks like a ventricular fibrillation. So very important to obviously look at your patient. And if your patient has what appears to be a very abnormal heart rhythm on the screen, but they clinically seem very normal, then obviously monitor them very closely, but also look for the opportunity for artifact. Some issue with a wire, a lead, something along those lines. Operator technique. So just like most of the things that we do in healthcare, whether you're a nurse or a respiratory therapist, again, technique is a lot. There's no substitute for experience and becoming proficient with various diagnostic and therapeutic techniques. Lead placement limitations, other technical issues just related to the clinician, related to the equipment and things along those lines. Like a lot of what we do, the analysis of the EKG is done in a stepwise fashion. So when we assess a patient in general, we assess them in a stepwise fashion. We look at them. We look through the various bodily systems in the electronic health record, or if it's just a hard copy, the chart itself. And we do a lot of deductive reasoning, a lot of collaboration with other members of the healthcare team in order to analyze what's going on. Likewise, with an EKG, we're doing a similar process, but it's focused, strictly on the rhythm strip that we're getting as part of the overall clinical picture of the patient. So the first thing we're doing is we're looking at, is the rhythm a lethal rhythm requiring immediate attention? So does the patient look really bad clinically and it looks like there's, a ventricular fibrillation or a ventricular tachycardia going on that requires immediate attention? Is the rate normal, slow, or fast? Is the rhythm regular? Is there a P wave? And the P wave, again, is that small wave that precedes the QRS interval. What is the PR interval? What does the QRS look like? Is it widened in some way? Is it narrow? Are there other characteristics such as ST depression, axis deviation, or some other abnormality? What is the final interpretation? And probably most importantly, what's the recommended action or treatment? There's a lot of ways to actually calculate, if you will, the actual rate. So with modern technology the way it is, the rate is pretty much spelled out on the monitor. But I know that when I recently took the ACCS exam, and for you nurses out there, it's the Adult Critical Care Specialty for Respiratory Therapists, and there was definitely fairly heavy emphasis on EKGs, just as there are in ACLS. And I think there was actually one question where they actually wanted you to know, they wanted you to be able to calculate the actual rate, the heart rate, based on a rhythm strip. And I know in ACLS they want you to do this as well. So each one of the big boxes account for 1/5 of a second, or 0.20 seconds. The small boxes are 0.04 seconds. So the first step is kind of knowing, what the grid lines actually stand for when you're trying to actually figure out what the rate is. Now, to build on the preceding slide, you can estimate the rate if it's irregular, such as you might see with atrial fibrillation. You can use what's called the 6-second technique. So you select a 6-second strip, that's 30 large boxes. You count the number of QRS complexes and you multiply them times 10. So in this particular strip, it's a 6-second strip. You see that there's 7 QRSs. You multiply it times 10 and you end up with about, and I say about because you're approximating a heart rate of about 70 beats per minute. So that's one technique. Another technique, if the rate is regular, is taking a look, picking a complex that falls on a heavy line. Then estimate the rate by counting the heavy boxes in between the next, if you will, QRS complex. And basically what you're doing is, if there's, for instance, 1 box, it would be a rate of 300. If there's 2 boxes, it's 150. If there's 3 boxes, it's 100, and so on. 4 boxes, 75, etc., etc. Again, if you're actually working in an ICU or even in a step-down unit, many times it's not necessary to do this. However, for our credentialing exams, for our, American Heart Association, certifications and things along those lines, this is absolutely a good thing to know. And this slide is just building on the preceding one. We are counting the number of boxes between 2 beats, or between 2 QRS complexes. You can then divide the number into 300, and some of the examples here, 2 large boxes are 150. So this is just kind of another way of looking at the technique that we discussed in the preceding slide. 6 large boxes is a rate of 50, and so on. Now, before we take a deeper dive into some of the abnormalities we're going to be focusing on, let's look at what's normal. So the normal values for an average adult, the heart rate is 60 to 100. The books are pretty much unified, whether you're a nurse, an RT, a physician assistant, etc. They're pretty consistent with that. PR interval is typically 0.12 to 0.20 seconds. So again, up to 1 large box with the PR interval. And the QRS is equal to or less than 0.12 seconds. And as I alluded to earlier on, a lot of the abnormalities you're going to see are going to be related to, the rate. It's going to be related to the intervals, the actual, how wide the QRS is, and things along those lines. So now let's take a look at abnormalities. And the causes of these abnormalities fall into a few categories. The first of which is there's a disturbance in automaticity. Okay, so the pacemaker speeds up, or as I talked about earlier on in the presentation, a new, generally slower pacemaker takes over. It can also be a conduction problem, slowing or blockage of the conduction or electrical pathway. There can also be a combination of the two that account for dysrhythmias. So sinus bradycardia, by definition, is where the heart rate itself is less than 60 for an adult. However, the actual rate is regular. There's 1 P wave for every QRS. The PR interval is somewhere between 0.1 and 0.20 seconds, or 1 big box. And the QRS width is 0.12. So basically, they're saying that the ECG is normal, with the exception of the fact that the actual rate itself is less than 60. And I will tell you, I'm 63 years old now. I realize we're recording this, so it'll probably be recorded when I'm 64 as well. I'll be in June of 2022. But my normal heart rate runs in the 50s. I actually earlier today I was out. I ran about 4.5 miles. I run very slowly, whatever, but I try to get my aerobic exercise in regularly. And if I concentrate on it and concentrate on relaxing, do a little biofeedback, I can get my rate actually below 50. So again, you can get some individuals who are in general in good health or reasonably good health, and it's really the result of athletic or aerobic training that accounts for their heart rate being south of this. So some of the common causes, as I just alluded to, the normal athletic heart is a possibility, but also could be a myocardial infarction or an MI, vagal stimulation, or increased in intracranial pressure, where you actually have some issue going on with the autonomic nervous system because of the increased ICP and the heart rate being elevated because of that. Treatment, it may be nothing if it's asymptomatic. Atropine may be given, and the latest guidelines are you give a lower dose of it. It's actually a half a milligram, used to be higher than that. And one of the other treatments that in ACLS they really want you to focus on, if the patient is symptomatic, is pacing the patient and getting them connected to a pacer as soon as possible. So now let's take a look at the opposite end of the spectrum. That is individuals that have a fast heartbeat. Now, one of the more benign forms of a fast heartbeat is known as sinus tachycardia. The heart rate is between 100 and 150. The rhythm and the intervals look okay. They look like they're within normal limits. Common causes are hypovolemia, fever, pain, anxiety, activity, including aerobic activity, and catecholamines, such as medications like albuterol and analogs of albuterol. The treatment would be to treat the underlying cause. If it's because of activity, it's just part of the normal training effort, and there is no treatment. Now, supraventricular tachycardia is more severe, if you will, more concerning than sinus tachycardia. The heart rate is higher. It's 150 to 250. The P waves may not be visualized because they're buried in the preceding T waves. Therefore, the PR interval may be difficult or impossible to actually measure. The other disconcerting part of supraventricular tachycardia is when the heart rate starts to exceed 160, 170 for adults. What happens is cardiac output will drop because there's insufficient filling time for the ventricles. The other bad part is that oxygen uptake will increase. So you end up with this, you have less cardiac output, and as the heart rate goes even higher, the cardiac output will drop further, the oxygen uptake increases. So your heart accounts for between 20 and 25% of your oxygen uptake. So you're kind of in this bad, vicious cycle type of deal. Best to actually intervene and get this under control. Common causes are ischemic heart disease and excessive catecholamines such as epinephrine. Treatment will include beta blockers or calcium channel blockers. And in certain circumstances where, again, the heart rate is starting to really exceed 200, they may actually use adenosine, which will cause a very brief AV blockade with the hopes of having the appropriate pacemaker take over and the heart rate restored to something that's either normal or closer to normal. Atrial fibrillation, not to be confused with ventricular fibrillation. So atrial fibrillation is where the upper chambers of the heart, the two atria, are quivering. And it's the hallmark of it is where the baseline is kind of a squiggly baseline and the actual QRS is irregular. It's singularly one of the more common dysrhythmias. It's characterized by there's no identifiable P waves, chaotic irregular baseline. The QRS distinguishable, so you can see it, but it's irregular. So sometimes when you're taking a patient's heart rate and you notice that the rhythm is irregular many times, not always, but many times, it's owing to atrial fibrillation. Common causes are an enlarged atrium due to CHF, mitral stenosis, and in some cases when patients have been a third spacing, so they've been given all this fluid, the third spacing, and now that fluid is now going back into the intracellular space, sometimes you can get an engorgement of the heart, and you can get atrial fibrillation because of that as well. Clinical significance. So there's also, because the blood that's in the atrium, it tends to be kind of circulating around the atrium and not being flowing as smoothly into the ventricles. You can actually get emboli formation. So one of the big concerns with atrial fibrillation is these patients are prone to blood clots. And if they develop a blood clot, particularly in the right atrium, it's going to end up in the pulmonary vasculature as a pulmonary embolism. So it can be potentially a big deal. The other thing that happens is because now the heart, if you will, coordination with the atria and the ventricles is now thrown off, cardiac output will drop. So there is this loss of what's known as the atrial kick. So it's this kind of, the smooth lub-dub is not happening the way it should. So because of this lack of coordination, cardiac output can drop, 10, 20%. Rarely in and of itself is it life-threatening, but it's something certainly to be aware of, particularly for a patient who may already have a low cardiac output. The treatment are beta blockers, giving you an example here, calcium channel blockers, digoxin, and a synchronized cardioversion would be another one as well. Atrial flutter is characterized by a sawtooth-like baseline. It's in the, if you will, family of dysrhythmias along with atrial fibrillation. So the P waves may not be present. They're actually buried in the sawtooth. The PRI is not measurable. QRS is generally less than 0.12 seconds. The rate itself, again, may be irregular. Common causes are ischemic heart disease, and not that you see it commonly, but rheumatic heart disease. So an individual that had rheumatic fever developed rheumatic heart disease. Even it may not have been detected. It may actually be detected like later in life when they develop atrial flutter. The treatment, by the way, is essentially the same for atrial flutter as it is for atrial fibrillation. Now let's take a look at the ventricles and the dysrhythmias that can occur that are impacting or actually originate from the ventricles. Therefore, they'll have in the name of the actual dysrhythmia, they'll mention something to do with the ventricles. In this case, it's a premature ventricular contraction, or PVCs. PVCs can be relatively benign if they occur occasionally. If they occur commonly, let's say several times a minute, if they are what we call multifocal. So I have two strips in this slide. The upper strip is just, a single PVC on a rhythm strip. Again, we don't have the luxury of looking at how many times a minute this was occurring, etc. But basically, you're looking at a single PVC. The strip beneath it has more than one PVC. So that in and of itself is disconcerting. The also shape of the PVC. So PVCs are kind of elongated, irregular QRSs, but notice how there's at least three that are shown in this lower strip, and all three look different. That means that they're originating from different portions, if you will, of the conducting system. And it's more disconcerting because it's suggestive. It's not just one irritable foci. It may be something that's more severe and needs more immediate attention. So, and again, for individuals who develop an occasional PVC, it could even be they've developed a less of a tolerance for caffeine and they drank too much coffee, something along those lines. They're undergoing stress, and they're having an occasional PVC. It needs to be monitored, but it tends to be categorized as something that's not necessarily life-threatening. When they're multifocal and occurring commonly, it's kind of the opposite end of the spectrum. It can be very disconcerting. So again, you're looking at what makes it a PVC. Premature beat makes the rhythm appear irregular. PVC is not preceded by a P wave, and the PRI is not measurable because, again, you don't have a P wave. Common causes are hypokalemia. So you have individuals that develop electrolyte irregularities, such as that involving potassium. In particular, low potassium or hypokalemia can be a cause. MI or ischemic heart disease, hypoxemia, hypovolemia. So again, you fix some of these underlying issues, and then you can potentially fix the problem that's manifesting itself as a PVC. Treating the underlying causes, beta blockers, antidysrhythmic drugs such as amiodarone or a lidocaine can also be effective. So now we're getting even more severe. Ventricular tachycardia, and some say that ventricular tachycardia is tantamount, is roughly the equivalent of continuous PVCs. So you can kind of see what you're looking at here. The rate, is generally between 100 and 200. P waves are not present, therefore the PRI or the PR interval is not measurable. The QRS is wide and bizarre. Width is generally, greater than 0.12 seconds. Common causes are similar to PVCs for the reason that I mentioned a moment ago. Treatment, if the patient has a pulse and is stable, and I say they appear stable. If a patient has ventricular tachycardia, this is something that is absolutely life-threatening. So they may be stable for the moment. There's a saying basically that goes like, if a patient remains in ventricular tachycardia long enough, they're not going to be stable. So if they have a pulse and they're stable, similar to antiarrhythmic drugs, as PVCs, so amiodarone, starting that immediately, and very close monitoring. If they're pulseless, then you basically treat it like a code blue and you begin CPR, hopefully with rapid defibrillation. We get even more severe as we go here. So this is ventricular fibrillation. It is actually coarse, because there's also fine ventricular fibrillation where it's just less sawtooth-like. What makes it ventricular fibrillation is as chaotic rhythm. The heart rate cannot be determined. P waves, PRI, QRS are not discernible. And what's happening here versus atrial fibrillation is basically the ventricles, the pumps, are just quivering. So there's electrical activity, it's chaotic, and the patient probably has zero or near zero cardiac output. Causes can include, or common causes include, a myocardial infarction or ischemia, acidosis, your hypothermia, hypoxemia, and then the treatment is really your CABDs, if you will, of ACLS. So, you start your compressions, you get your airway, you get your breathing, and then obviously the defibrillation is something that you're trying to do as soon as possible. So you're doing that simultaneous to assessing the patient and then beginning compressions and getting an airway opening and, breathing for the patient, etc. So it's a code blue, treated as a medical emergency, needs immediate attention. And really the key is getting them rapidly defibrillated, because the longer they stay in ventricular fibrillation, the less of a chance is we're going to snap them out of it. Asystole is when there is no discernible electrical activity on the ECG or EKG. Now, a few words of caution. It's important to make sure that you're not diagnosing something as asystole and the patient is sitting up in bed looking at you, engaging you, et cetera, et cetera. So that may just be something's not connected. The if you will, defibrillator or monitor is in some sort of a test mode, something along those lines. So obviously very important to take a look at your patient. But assuming it's actual asystole, unlike what they show you on TV, they start shocking the patient as if you're starting a car. That's not going to be the case. So that's not one of the treatments, by the way. So the causes are electrolyte disturbances, pneumothoraces, drug overdose. So your H's and your T's, if you recall back from ACLS, hypoxemia, post-MI. Treatment, again, it's not shockable, immediate CPR, unless the patient has a valid DNR order. Identify and treat the underlying cause, pacing the patient, and basic troubleshooting of, with the deductive process that you go through to see, is there an obvious cause that we can quickly remedy. So let's take a look at pulseless electrical activity, or PEA. In the preceding slide, we looked at asystole. where there was no measurable, if you will, electrical activity. In PEA, you have measurable conducting going on, and it's measurable via a rhythm strip on the ECG or EKG, but you do not have a pulse. You do not have mechanical activity of the heart. And this is where the H's and the T's need to be further investigated. As you guys, if you're ACLS certified, you're familiar with these. When I go for ACLS certification, I review this stuff as well. So I'm not proud. So the H's are hypovolemia, hypoxia, or hypoxemia leading to tissue hypoxia. Acidosis, either high or low serum potassium, or hypokalemia, hypothermia. The T's are cardiac tamponade, where you can have, let's say, a pneumomediastinum, that's, if you will, squeezing the heart, tension pneumothorax, which is obviously a different mechanism, but can also squeeze the heart. Thrombosis, so you have an MI, a cardiac, a clot in the, cardiac vasculature, a pulmonary embolus, and then we say tablets here, but a drug, either an intentional or an unintentional a drug overdose. So you do this in a stepwise fashion. You say, do we have anything of these present? If we do, can we reverse them quickly? Now, I mentioned first degree heart block earlier in this presentation. It involves where the PR interval is greater than 0.20 seconds, greater than a fifth of a second. So the actual rate is regular. It's between 60 and 100. The QRS looks like it's fine. Again, everything else looks like it's fine, except you have an elongated PR interval. The causes, so it can be physiologic interference with the conducting pathway. So if someone had an MI, it affected the conducting pathway, and in a manner that manifested itself like you just have a prolonged PR interval. Digoxin toxicity, so dig is not commonly used, but it still is. So if too much is given, it can actually be trying to fix one problem and cause another. Treatment may be benign, so monitoring the patient for any sort of further worsening of the condition. Treat the underlying cause. If it's a dig toxicity, stop the dig, and again, monitor your patient very, very carefully. This is one of your more benign, in and of itself, more benign dysrhythmia. Now with second degree heart block, you actually have two types. So Winky-Bach is type 1. It involves an irregular rhythm. The ventricular rate tends to be less than the atrial rate. So you have a QRS that's dropped, okay? You have progressive prolongation of the PR interval until a QRS is dropped. And there's a saying, longer, longer, longer drop. Now you have a Winky-Bach. I didn't make that up, trust me. But basically the longer is the PR interval gets progressively longer until the QRS is dropped. Causes or MI or ischemia, excessive beta blockers, dig toxicity, or there's other causes, but those are the most common ones. The treatment involves atropine if the patient is symptomatic. They have a heart rate of less than 60, so they have fewer than 60 QRSs per minute. Or monitoring the patient to see if it's kind of a steady state, or if the patient it's getting worse. Second degree heart block type 2 is you don't have this progressive elongation. Okay, you do have, again, you have some P waves without QRSs, so for some reason the QRSs are dropped, but it's not this, again, progressive prolongation. So you have a regular rhythm. Ventricular rate is always less than the atrial rate, so there's more P waves than QRSs. QRS does not occur, it's another way of saying it, with every P wave. More P waves than QRS. I think I said that 3 different ways, but you get the point. Causes are MI, ischemia, excessive beta blockers, dig toxicity. The treatment would involve, if it's dig toxicity, stop the dig. Atropine if the patient is symptomatic, potentially pacing the patient as well, and monitoring them to see if the patient's symptomatic. They probably will be symptomatic at some point, particularly on exertion. but just monitor them. If it's in a steady state, they may or may not actually treat it. But as you go from a first degree to second degree, and I'll talk in a moment about third degree, they tend to be, progressively more life-threatening or more serious, and they need to be, monitored and probably intervened with. So before I actually go into the actual causes of third degree and the manifestations of third degree heart block, what I'll say is this. My wife's a cardiac nurse, and she explained it to me. It's, so in a normal, heart conducting system, any mechanical activity, you have this coordination between the upper chambers, the atria, and the ventricles. With third degree heart block, the atria and the ventricles are not coordinating themselves. They're just doing their own thing. Okay, so you have the atria beating at their rhythm, and you have the ventricles doing their own thing there. And you could just imagine for a minute, before we go into the technical aspects of this, it can't be good. If you have the upper portion of your heart not coordinating with the lower portion and vice versa, you got to think to yourself, nah, this can't be good. Cardiac output is affected. It could further degrade into another dysrhythmia, etc. So again, you have independent atrial P waves and ventricular activity. The atrial rate is always faster than the ventricular rate. Heart rate is often less than 40. So you have, perfusion issues going on. PRI is not measurable because you have this lack of coordination, and the QRS may be wide, may be greater than 0.12 seconds. The causes are MI, ischemia, digitoxicity, and the treatments are actually similar to, particularly to the second degree type 2. This is a sick patient. They need to be intervened with. They need to be monitored very, very carefully, and they're potentially at risk for further deterioration from a cardiac perspective. So let's take a gander at the idioventricular rhythm. What characterizes an idioventricular rhythm is the lack of P waves, and generally speaking, the rate is a slow rate. Okay, this is a sick heart. So if you're just kind of just talking, like we're not talking technical terms here. We're saying, is this a sick heart? Yes, this is definitely more severe than some of them, than things like atrial fibrillation. Certainly more severe than sinus tachycardia, sinus bradycardia, etc. What makes this idioventricular rhythm again? So you have this ectoptic foci. So it's this origin of the signal, of the electrical conducting signal, takes over as the pacemaker for the ventricles. There's no P waves. There's a wide, kind of bizarre looking QRS. The rate is generally 30 to 40. There is such a thing as an accelerated idioventricular rhythm. There is such a thing, but in the main, in general, no P waves, this wide QRS, and a rate of 30 to 40. Common causes are an MI, so basically the heart attack has kind of knocked out that dominant pacemaker that's going to result in, the nice, PQRS, the rate of 60 to 100, that's been knocked out. Treatment or pacing, atropine, but again, this is usually an indication that the heart itself, the myocardium and the conducting system have taken a major hit. So many of you have heard the term, you've encountered it in a clinical setting, you might have encountered it in your personal life with a loved one or a friend or whatever the case may be, is a STEMI. So STEMI is a ST elevation MI. Okay, so what you're looking at in that the B there, in the upper line there, what's labeled B, is a myocardial infarction, and one where you actually have the ST segment, if you will, is elevated. It's one of the hallmark signs. So STEMI means ST elevation myocardial infarction. When you have ischemia, so now you don't have tissue that's actually been stunned or died. You have myocardium that's not getting as much oxygen as it needs, so it's ischemic. And what typically, not always, what typically happens there is you will actually get an ST depression. Okay, so you get an ST depression with ischemia, but with a full-blown myocardial infarction. You have an infarct, so you have no blood flow that's actually serving that particular portion of the heart. you have an ST elevation. There are non-ST elevation MIs, but again, this one is depicting up on the upper right-hand side there what a STEMI would look like. The patient will undoubtedly complain that they have chest pain, it may be radiating to the jaw, they may be diaphoretic, etc. The exception there is you do get some patients that are having an MI, but you get women who I'm saying this, some women they just don't show the amount of symptoms. You get individuals who are they have diabetes and they have some nerve issues, so they may actually be having a full-blown, they don't feel right, they don't have exercise tolerance, they maybe can't even walk around, but they're not experiencing a ton of pain, but they're then hooked up to an ECG and we see that they're in fact having an MI. But many of these patients will be symptomatic, will have pain, radiates to the shoulder and the jaw. As I mentioned earlier, diaphoresis and other symptoms that are typically associated with an MI. This is just another strip, another way of depicting the ST elevation, but this also has PVCs with it. So I mentioned earlier that if an individual has multifocal and frequent PVCs, one of the causes can be an MI. So this particular patient there, this strip is showing you the ST elevation with a PVC. Again, the cause would be an acute MI. And the distinguishing acute from non, patient could have had an MI a month ago, and it will show up on the strip in all likelihood. But in this particular instance, they're actually having their heart attack as we speak. The treatment would be possibly a TPA, which is tissue plasminogen activator. So it's clot busters. And for facilities that don't necessarily have a cath lab, now we take this for granted. If you live in a urban or suburban area, well-populated area, you probably have multiple hospitals that have cardiac catheterization labs. Maybe they do bypass surgery, et cetera, et cetera. But in more remote areas, they don't have access to all this. So TPA may be the actual treatment of choice. Vasodilators, may be coupled with TPA. They may go to the cath lab to actually open up the coronary arteries, and revascularization would be they may go to the cath lab. Some of those blocks may not be reachable, so they may actually also end up having bypass surgery as well. The key is that they need to be treated very, very quickly. They need to get to that cath lab very quickly. They need to, if they don't have access to that, they need to get their TPA very quickly in order to minimize the damage to the myocardium. The longer it's deprived of oxygen, it will initially be stunned. And some of that may come back, but if it's deprived of oxygen for a longer period of time, it's not just a matter of it being, the myocardium being stunned. It will die. It will, form scar tissue, and the patient will have, will not have the same cardiac function that they did before they had the MI. This is just showing you another depiction of ST segment depression associated with myocardial ischemia. Treatment would be vasodilators, oxygen, possibly going to the cath lab, quite possibly getting a bypass surgery. A detailed description of axis deviation is beyond the scope of this presentation. We would simply never be able to get through it, the entire presentation, in the amount of time that's allotted. However, not to discuss it at all would not be appropriate either. So a few words about it. So in identifying axis deviation, so normally what you would see in lead 1 is you would see a positive deflection. Lead 2, you would see a positive deflection. Okay, so the axis interpretation, it would actually be deemed normal as far as axis only. In a left axis deviation, lead 1 would be positive and lead 2 would be negative. In a right axis deviation, lead 1 would be negative and lead 2 would be positive. So it would be the opposite that you'd see in left axis deviation. In extreme right axis deviation, you will see both leads 1 and 2 both be negative. One other thing to note, with right axis deviation, lead 3 will be positive, but taller than lead 2. A word or two about the causes of axis deviation. So one easier way to remember it is right axis deviation would be associated with right ventricular hypertrophy, like you would see with right heart failure. And it kind of makes sense because what's happening is the conducting pathway is longer. That right heart is, if you will, it's bigger, and the pathway has to travel further, so it's actually resulting in a deviation, in a right axis deviation. COPD, and it may be cor pulmonale associated with COPD, acute PE, or pulmonary embolism, because you have that right side, particularly the right ventricular engorgement because of the clot that's downstream. Infants, it's normal. I don't really want to go into that. And biventricular hypertrophy, that's really saying that both the right and left heart are enlarged. You'd actually, you could well see that in that condition. Left axis deviation, for similar reasons as right axis deviation, you'd see it in left ventricular hypertrophy because the conducting pathway is, if you will, elongated on the left side of the heart. See it abdominal obesity. You actually have, if you will, abdominal pressures that are being exerted on the apex or the bottom of the heart. For similar reasons, ascites or large abdominal tumors. And also because of these mechanical reasons, you'll see it in women in their third trimester of pregnancy, because again, you have the, if you will, the fetus and the placenta and placental contents that are actually pushing upward on the, on the heart, resulting in the left axis deviation. So let's kind of sum things up here. Some of the take-home messages is, decide what it is, what's useful to you. I've been in acute care for a lot of my career, but I did do about a 2-year stint where I did home care. I learned a lot in home care. I learned a lot, just in the units the adult units that I work in. But again, decide what it is useful to you as a nurse or a respiratory therapist, and pursue it. Identify the resources, the texts that are out there, textbooks. Both in Egan's and my clinical assessment textbook, I authored the chapter on EKGs. It was something that I didn't know much about when I graduated from respiratory school, and I graduated from a very good respiratory school at University of Medicine and Dentistry of New Jersey, now Rutgers. But I really didn't know too much, so I embraced the notion of learning more about it. I started presenting on it, and then I started to edit chapters. Plus, my wife is a cardiac nurse, so she knows a lot about this stuff, so she was actually a tremendous resource as well. Looking at the manuals that are out there, including the American Heart Association manuals that are your library probably has their online, etc. Taking actual ECG or EKG strips and interpreting them maybe along with your respiratory or nurse or physician colleagues, kind of quizzing yourself along those lines. Review and reinforce, obtain and maintain ACLS. First few times I took it, I really studied pretty hard. Now I do spend a little bit of time reviewing stuff when I go to sit for it. You now need to take the pre-exam, so it's good to prepare a little bit, and know their limitations. So know what learn what you need to know. If you feel limited, like you want to know more about this, avail yourself. There's a ton of very good resources, some of which I'll be sharing with you in the next slide. So like I mentioned in the preceding slide, the Egan's Fundamentals of Respiratory Care for you nurses that are watching this. It is one of the sentinel textbooks in respiratory care. We're working on the 13th edition as you speak, and I just finished updating the chapter on ECGs for real. But there's a chapter in there on ECGs. There's also a chapter in my clinical assessment textbook. And Thaler has an outstanding, it's actually kind of, the book is dedicated to ECGs, but it's really simply put, everything you'll need to know about EKGs. And then there's a bunch of online resources that are out there that'll actually show you live strips, and we'll talk a little bit about what the patient's presenting, and kind of case studies and things along those lines. So there's some really, really good online resources that are out there. With that, this concludes this presentation. I want to thank you very much for joining us today. Hopefully you got something out of this. A lot of this is probably just reinforcement for things that you learned and maybe you don't use that much, so you maybe have forgotten or just a little bit hazy on. Hopefully this helped fill some of those gaps. Again, want to thank you for joining us today, and hopefully you come back to us. If you've been with us before, we want to thank you for that as well. But hopefully you enjoy these presentations, and you also will join us for some of the live webinars that we have, and occasionally we even have some events where we go abroad or we go to a location, and you can kind of have some fun and at the same time learn some stuff regarding various aspects of medicine and respiratory care. So thanks a lot and have a wonderful day. Bye.